Hi, everyone. Welcome to the January Myhre Patient and Family Research Q&A with Armelle. We're so delighted to see so many of you and from around the world. Without further ado, I will let Armelle jump straight into it. Today, we're going to be talking about fibrosis, something we've talked a little bit about before in the past, but I think as Armelle will attest, it's complicated. We want to ensure everybody understands the process. So today we're going to dive a little bit more into Myhre and how the effects that fibrosis have on symptoms. So Armelle, over to you.
Thank you, Kate. So just for a quick introduction, so I'm the Chief Scientific Officer of this organization. My background is in neuroscience and in pharmaceutical industry. So I'm not a medical doctor, so I'm not going to give you any advice on clinical care. I'm here to explain you the strategy we have in drug discovery at Myhre Syndrome Foundation and give you the scientific background on different aspects, biologic aspects of the disease so that you understand what we are doing and the choice we make in this strategy to find treatment. So I will start with going back to explaining a little bit fibrosis and TGF-beta that everybody hears about TGF-beta. Because I did already a session on fibrosis, but I think it was maybe a little bit too difficult. So I'm going back. And then at the end, since there are a lot of new patients, I can also make a kind of summary of what we are doing and the strategy we adopted in the organization to get as soon as possible to a treatment. So let's start first with the fibrosis. And please interrupt me when you don't understand a word, when it's not really clear. Just tell me, well, no, I don't understand, or ask questions. So I would like you to think of fibrosis as a wound healing process that goes wrong. It's when the repair process goes into overdrive. So going back to Myhre, why do we talk about, so it doesn't work, okay. Why do we talk about fibrosis in Myhre, and why do we talk about TGF-beta and all these big words for this syndrome? The origin of Myhre syndrome is the result of a mutation in a protein, a gene that gives a protein called SMAD4. So SMAD4 is at the end of several signaling pathways. So that means that it's the way to give message to the cell. And it's at the end of the pathways of a super family of different proteins that are called the TGF-beta family, and also interact with other type of families. So what is TGF-beta that you hear all the time? It stands for transforming growth factor beta. And it's a group of signaling molecules. So there are messengers between the cells, and it's a way of communicating and telling the cell what they should do. So it acts as to be simple, as a foreman at a cellular construction site, directing the cell behavior like building, demolishing, or specializing. So it's very complicated. You shouldn't. I showed you that figure just to show you that it's the TGF-beta here, or BMP, which part of the family. It activates so many different things, but you can see here it activates also SMAD4. You have SMAD4 that is inside this whole mess of molecules. So the signaling pathway goes to, I don't know if you see the thing on the, maybe I will reduce it. It goes through the integration of many different message given to the cell. So the super family of TGF-beta that I talked about is 33 members to make this family. So you have some names that maybe you saw somewhere. If you do some research, it's TGF-beta 1, 2, and 3. It's BMP, GDF, anti-Müllerian hormone receptor 2, MHR2. So there's a lot of different members. And at the end, it uses the main pathway it uses is called the canonical pathway, and it's SMAD pathways. That's the way they communicate with the cells. So the TGF-beta acts like a key fitting into a lock. It's a receptor on the cell surface, and then it initiates a chain reaction that eventually activates special protein called SMADs. So you have two types of SMADs. You have the regulatory SMADs, the R SMADs, that are the SMAD 2, 3, 158, and you have the co-SMADs, which is what interests us. It's the SMAD 4. So they form a kind of big complex, and they go on the DNA and give order to the DNA to produce other genes together with other transcription factors. So it's not just the SMAD4, it's not just the TGF-beta, it's also other transcription factor, which means that if you have a mutation and SMAD4 doesn't really work, it's gonna have an influence on so many message that the cells receives. Is it okay? Do you have any questions? Is it relevant? You say, well, I don't really care about that, or just interrupt me, tell me. I'm going to put you back.
Armelle, I'm going to interrupt you.
Yeah.
So for each area of the body, the pathway, the message might be slightly different. So you see a manifestation in different, you might be coming onto this, but so.
Oh, that's a really good question. Yeah, go ahead. Sorry.
No, that's it. That's mainly so understanding that also that the difference, like maybe, yeah, how does that affect the different symptoms we see because there's a different amount of messages?
Yeah, exactly. So if I go back, no, that's going up. So if I go back here, so you see that there are all these different members. So those members are going to, the cells in the different organs don't receive all these messenger at the same time. For example, in the bone, you are going to receive more maybe the BMP, which is in the brain or in the ovaries or also in the bones, you are going to receive more of the MAH receptor. And it will go through either the SMAD2/3, for this one, it will go through the SMAD158. But the thing is that at the end, everything comes to SMAD4. So that's the reason why, even if you have the anti-Mullerian hormone, for example, in the ovaries or in the brain that is secreted, you will have some effect because SMAD4 is also linked with that. And you will have the BMP in the bones, but at the end, it involves also SMAD4, so you will have also some problem in the bones. So that's the issue with Myhre, is that since SMAD4 is at the end of all these different message, it acts in different in a multi-system manner, in the muscles, in the brain, in the vessels, the cardiovascular system. So we have a multi-systemic issue and manifestation because we are at the end of all these different signals. Did I answer your question?
Yeah,
Kate?
no, that's perfect. Yeah, thank you.
Okay. So the goal of SMAD pathway is to control which gene get turned on and off. So why is it important to have a gene turned off? Because it's the only way to produce a protein. And the protein are the workers in the cells. That's what's going to make the cell work. So it's important that SMAD4 is going to say, produce that worker and bring how many workers, that many workers in the cell to do that job. So it's a different job depending on the cell. Then you have specific SMAD. So I went through that already. You have the SMAD 2 and 3 that will be under certain message, and other SMAD 5, 8 other numbers that will do other things. I will not talk about the SMAD7, which is a regulator of the SMAD signals. But what is important is that Myhre syndrome is due to a mutation in the SMAD4 gene, which means that the protein SMAD4 is going to be overactive. So all this message, this signal, these genes that are turned on or off, SMAD4 is going to overdo it. So depending on which SMAD, so that's exactly what I said before, the SMAD2/3 or the SMAD158, so the anti-Müllerian hormone, the BMP, the TGF-beta, will be different in every type of cell and will give different function. So the TGF-beta can affect whether cell growth and cell dividing cells, trigger the cell to specialize into certain type of cells, like the neurons, for example. So if you have a bad functioning or too much functioning of TGF-beta, the cells that are during the development, when you are an embryo, are not going to be specialized in the proper number and in the proper cells. Or TGF-beta can also trigger the message to the cell to say self-destruct. That's called apoptosis. So the effect of TGF-beta really depends on the type of cells receiving the signal and the environment of all the other cells. So I had a video just to show you how SMAD4 can trigger the gene, but I think we'll do that next time because I would like to go up to the ends. Maybe we can go back if you want to understand exactly how SMAD4 is going to trigger the gene. So we need to regulate this TGF-beta because it does so many different things, and if it's overactivated, it's bad. If it's underactivated, it's bad. So there is an intersect in everybody. We should be able to regulate this TGF-beta. So usually it's produced in inactive form, and we have different other protein that are going to activate it. And we have something very important. We have mechanical forces that can activate TGF-beta. So it's a kind of, if you have pressure, you will have overactivation of TGF-beta. So just remember that. The TGF-beta has beneficial roles. It's crucial for embryonic development, as I said, ensuring cells that are organized correctly. It helps regulate the immune system, preventing from attacking the body with your own tissues. So it means that it prevents what we call the autoimmune reactions. It's essential for wound healing, so helping to repair the damaged tissues. The complexity of TGF-beta is that it can be both beneficial and harmful. Depending on the context, it's going to be all these different roles, but if you go too much in that direction, then it becomes harmful. It can trigger tumors formation and have really harmful effect. I'm not going to go in too much in that in the harmful effect because I'm going to talk more about the TGF-beta and fibrosis, which is one of the harmful. I'm not going to go in the cancer triggering TGF-beta triggering cancer, but I would like today to focus more on the fibrosis. Because in Myhre syndrome, I think that's a process that worries everyone, is the fibrosis. So TGF-beta is considered a master switch driving fibrosis. So since SMAD4 is at the end of all the different type of TGF-beta signaling, you can imagine that SMAD4 overactivation is going to be also a switch to driving to fibrosis. So what's fibrosis? It's the deposition of the ECM, so this extracellular matrix it means, in fact, the gluey thing that you have outside the cells, in between the cells. And in this extracellular matrix, you have components like collagen. Everybody heard about collagen from the cream for your face or other source. We hear that word a lot. So that's a component of the jelly substance that is around the cells, which is the extracellular matrix. The other part of the fibrosis is not only this deposition of extracellular matrix, it's the formation of myofibroblast. So those cells are cells that are acquiring a kind of muscle-like behavior, and that are going to be able to contract the tissue around the wound that has been formed. So you can have really different type of fibrosis. So I just gave an example of liver fibrosis, for example, but you can have kidney, heart, lung, aorta, vascular, muscle, skin. So you have fibrosis in many, many different tissues. And since SMAD4 triggers fibrosis, you imagine that in Myhre syndrome, we'll have issues in all those different tissues. So up to now in drug discovery, in pharmaceutical industry, they were focusing on this extracellular matrix to fight against fibrosis. But in fact, in the last years, we realized that those compounds, those treatments that we have, do not work really efficiently against fibrosis. And in fact, now people are more and more focusing on the myofibroblast, the part of those cells that triggers the contraction and the stiffness, and the fact that they proliferate a lot around the wound that was created, and participate a lot in the formation of the fibrosis scar. So we are more focusing on that also in the organization, and the different strategy we have are trying to reduce the number of myofibroblasts in Myhre patients. So those myofibroblasts, they can come from very different type of tissues. They can come from the endothelial cells in the vessels, in your brain, in the aorta. They can come from epithelial cells in your sinus, or anywhere you have epithelial cells in almost all organs. They can come also in the liver from quiescent hepatic cells. In the skin, they can come from fibroblasts, mainly everywhere they can come from fibroblasts. And you have, for every different organ, you will have different type of cells that are going to be transformed into those cells that we don't want to have. Just a little bit for the wound healing, but not too much that triggers the fibrosis. Am I clear? Do you want to ask questions? Where are you? I can see you. No? No issues. Okay. Then I'll go on. So I was talking about the different type that affecting various organs and tissue in the body, the liver, the skin, muscle, cardiac, cardiovascular, even renal, and really, just to summarize what I just said, fibrosis is characterized by the excessive accumulation of extracellular matrix components, so collagen and others. And this leads to tissue remodeling, scarring, and organ dysfunction. So that's the up to now definition of fibrosis, but we are moving and adding something from that, which are the myofibroblast formation. So there are some common mechanisms and mediator in all these different organs fibrosis as common process. One is the TGF-beta. That's considered a cytokine. I'm sure you heard about that during COVID, the cytokines. So TGF-beta is one of the cytokine, and it induces the deposition of ECM, but also the formation of myofibroblast. So the myofibroblast are really the primary effector cells in fibrosis. They also trigger ECM synthesis and remodeling. The inflammation is something in common to all the fibrosis. At one point, you have inflammation. In some cases, the inflammation stops and you are blocked in the late phases of the wound healing and fibrosis progression. But at the origin, there is a lot of inflammation. The DEMP, which are in fact the different deleted part of tissue or cells that are broken, that also activate an immune response and promote fibrosis, and the SMAD signaling pathway. The SMAD are really play a key role in fibrosis. Another thing that is interesting is, so I was talking about TGF-beta. There is another type of family of sending signal to the cells that is called Wnt. So the Wnt pathway. And what's really interesting is that the SMAD4 is also able to get the Wnt pathway information to the nucleus. So if you overactivate SMAD4, you overactivate TGF-beta, but you also overactivate the Wnt pathway, which up to now for scientists or clinicians were two things really different and two different pathways. But in fact, with SMAD4, we realized that you are going to integrate those two things. Am I going too much into details? You're lost, you're not interested? I'd like to have some feedback.
I'll ask a couple questions. It's Kathy. So you don't have to have, like, say the heart, for example, the pericardium. So you don't have to have inflammation. Do you have to have inflammation or some sort of damage to initiate the process, or can it be from one of those other, just from one of the other things that you were talking about? Is it a combination of those, or just one of those many things that you've been talking about?
So you can have at least, you need to have at least one thing that is going to trigger the fibrosis. So either it's a mechanical force, so you press on something, either there is an aggression by, I don't know, it can be food, it can be smoke, it can be any type of aggression. It can be a reaction of your immune system that is starting with a kind of autoimmune aggression of your body. And all those combined with the fact that you have a genetic issue with SMAD4 mutation will trigger the fibrosis. So it's not that it comes from nowhere and suddenly. There must be a signal at what moment that initiates the wound healing process, the normal wound healing process. The issue is that, and you have that all the time, every time. When you speak, when you drink, when you drink something too hot, or you have aggression of your body all the time. You have a viral infection, then your immune system reacts. So the body is all the time under aggression. The issue is that some type of aggression combined with the genes mutation will trigger the fibrosis in overdrive. And what I'm going to talk about later is why do we have, I mean, nobody has the exact answer, but we have clues about why some people are going with Myhre syndrome are going to overdrive in fibrosis in in the pericardium, and other are going to not have fibrosis, and other, I mean the heterogeneity in front of fibrosis, I'm going to talk about that also. Did I answer?
Yeah, yeah, thank you. Yeah.
I do have a question. So since we need to have something that initializes the fibrosis, so when for example, if one of the Myhre patients gets hurt externally, has a wound somewhere, why sometimes it's the reaction of the fibrosis when they have a wound externally can be seen more, whereas in other places when they are hurt, when they have an open wound, there is less to it. Because I realized with my daughter, she's had 8 open heart surgeries and a whole bunch of other things, and whenever she gets wounded or she has a little wound somewhere, I never know, is there now going to be a lot of the fibrosis thingy that builds a scar and becomes like a big scar? Is there a difference? Do we know when there is more of fibrosis going on when they are hurt, the ones that have Myhre, or do we know anything about that?
Not especially on Myhre, because it has not been really studied. But the thing is that the scar from the skin involves many different type of cells, and it involves epithelial cells, but also adipocytes.
Mm-hmm.
And adipocytes can be transformed in fibroblast and myofibroblast, also through some other pathways. So that will depend, in fact, on the type of cells that you have around the wound. So if you are on the skin, the wound will be different and the fibrosis will be different as if you have, for example, tracheotomy or intubation, and it will be different from a surgery, cardiac transplant, or these kind of things, because the cells that surround the aggression are not the same. It's different cell type. And one other origin of the myofibroblast can be also the bone marrow that are going to produce some immune cells and different what we call the MSC, so that's the mesenchymal stromal cells. And those will react differently, but react also very strongly to TGF-beta. So SMAD4 also will have this effect. But for example, the epithelium in the pulmonary, in Myhre, are not really prompt to fibrosis. So you will not have the same type of fibrosis as cystic fibrosis or IPF patient, for example. So it shows that it really depends on the type of cells where the aggression is going to be. Did I answer your question?
Yeah. Yeah.
So I wanted to talk a little bit more just to because I think it worries some people in Myhre, is the what we call the LTS or the SGS. So I'm French, so that's going to be a challenge. Laryngotracheal and subglottic stenosis. Did I say it properly? I hope so. So that's one of the issue of Myhre. We are not the only one. That's not there. There have been now 20 genes that have been associated with this type of fibrosis. So it's not only the SMAD4 gene that triggers that, and the issue is the narrowing. So what causes that narrowing? It's in what we call SGS. So sometimes it just appears out of nowhere. That's what is called a spontaneous occurrence. So we don't know exactly where it comes from. And sometimes it's developed after some injury to the airway, so intubation, for example. So we are more and more trying to identify which type of cells so that we can identify the proper treatment, because if we know which type of cells is going to trigger the myofibroblast, then we will be able to act on those pathways. So we know that the macrophages under the TGF-beta are going to go to trigger this formation of myofibroblast. And it's also current in idiopathic subglottic, so TGF-beta is always there. And we try to identify which type of aggression, so which type of bacteria can trigger more injury and more fibrosis response. Because now we understand more and more the way we react to certain type of bacteria and what's happening inside the cells, so we can act directly there also to stop the fibrosis. So in the early stages of a wound healing, what I explained, and I hope you understood now, is that the TGF-beta is actually helpful. It brings the immune cells to the injury, and it stimulates the production of collagen and other protein from the ECM, so that it makes the repair. But the issue with Myhre is that it's like a construction foreman making sure that the building happens properly, and it goes over that because the SMAT4 is working for this foreman, but is working too much. So in Myhre, sometimes the construction crew, let's say, gets a little overzealous. So they keep building even when the job is done, and it results in an excessive scar tissue and fibrosis. So what we are going to understand now in the foundation, one of our strategy is to try to understand those workers, those builders, what type of bricks they use to make the scar. So what I call bricks is I refer to the myofibroblast. So where does it come from? And if we know where it comes from, in the case of Myhre syndrome and the fibrosis of Myhre syndrome, then we can stop this transformation and we can stop them having all those bricks. So if they don't have any bricks anymore, they are going to stop. So that's a bit the strategy we have now. So what are some of the things that can make TGF-beta signaling go rock like that? So that was the question from Kathy. So mechanical stress, intubation, or other kind of intubation will be mainly, or surgery is going to, as I told you at the beginning, it's going to overactivate TGF-beta. TGF-beta is really sensitive to mechanical stress. So if you do a mechanical stress or if you do an injury, then TGF-beta is going to go overdrive. So it's like squeezing a tube of toothpaste to squeeze more out. And in case of stenosis, you have the beginning of the fibrosis, which trigger the stenosis, and the stenosis triggers more fibrosis because it triggers more mechanical stress. So it's a never-ending story. It's really going in circle. The other problem is the chronic inflammation. So that's a major driver for fibrosis. Inflammation is the body natural defense system to respond to injury or infection. But the problem is that it should be short. You cut, you repair. The problem with chronic inflammation is that you have some of the immune cells that are called the macrophages that are in kind of first responders that are going to clean up the injury. In case of chronic inflammation, they stay too long on the site, and then they are going to trigger too much myoblast formation, too much ECM composition, and this will increase the TGF-beta activation, increase the amount of myofibroblast, and this makes the tissue really stiff and with a big scar. So that's
Armelle, I have a
Yeah.
question.
Yeah.
Is this pathway more prevalent in the larynx and subglottic area, or is this all over the body?
So the TGF beta is all over the body. The issue we saw with, I don't know if it's really the answer, but the issue we saw with the Myhre syndrome is that you have also deficiency in the immunoglobulin A, which is the way to defend your airway. Those are the fighters, if you want, not the macrophages, but they are also from your immune system to defend your airway and your gastrointestinal tract. And since you have less, then you respond less to those aggression, and you are more prompt to have a kind of chronic inflammation or an overreaction when other people with more immunoglobulin A will have an immediate reaction to the aggression and solve the problem. So that's one of the thing that we were talking about with other scientists about Myhre. For the subglottic stenosis and laryngotracheal stenosis, we have those 20 genes, over 20 genes. Some are X-linked, so linked to the chromosome X. But mainly, all of them somewhere have the TGF beta pathway in them. Did I answer your question?
Yes, thank you.
So the last thing, and then I will have more an open discussion with you, is the talk about the inequality in confrontation to fibrosis or other manifestation in Myhre syndrome. So it's about the heterogeneity of the manifestation. You will have the patient with exactly the same SMAD4 mutation. Some are going to have cardiac malformation, some are going to have intellectual disability, and there is really heterogeneity, and there is very low genotype phenotype, what we call correlation. So you have the same gene mutation, but you don't have the same results. So, and it's not only in Myhre syndrome, it's in many different rare diseases or diseases, genetic diseases. So the scientists for the past few years have been really thinking, where does that come from? There must be a reason why. So again, it started from oncology, where they saw that some people that have a mutation that should trigger a cancer do not have this cancer. So they started to look for the reason, and they found that they have a variant, another mutation in another gene that counterbalance the defect of the first mutation, and that in fact rescue the people. So that's what we call now the genetic suppressors. So it's a genetic variant. It's not pathologic. It's not because you have that variant that you are going to have a disease, but that those mutation can protect you from pathological defect triggered by another mutation in another gene. So that's the what we call in science the co-occurrence of mutations in query suppressor gene pairs. I know it's a lot of very scientific words, but it's mainly another. You activate something too much, and then you are going to have a mutation in something else that is going to, for example, remove all these bricks that SMAD4 wants to pile up. So at the end, it will compensate the fact that SMAD4 wants to pile up so many bricks. So, do you understand the concept, or am I not clear? just a yes or no?
Yes, it's clear.
Okay, thank you.
But then if you know that, or if we know that we do have in other genes, other components that apparently equalize what the SMAP4 does wrong or what's happening with the myoplastic thingy, if we know that, can we not when we do when we check via the blood what is in the DNA, and we see with the Myhre people, can we not give them more of what they're missing in another gene? Isn't there a possibility where we can find out?
Exactly. So that's really a new way to uncover new therapeutic strategies, is to identify those co-occurrence mutation, those genetic suppressor. We need to identify them, and then we can first understand better the mechanism of the disease, and we can act on them. So I'm going to stop sharing because I want to see people. Yeah. So the issue is that first we need to identify those genes, those variants, those suppressor genes, which means that we need to do whole genome sequencing on people that have the same mutation but different clinical manifestations. And we need to have enough people to have it statistically valid. In a disease such as Myhre syndrome, that's the issue. Even if we have everybody sequenced, have their whole genome sequenced, the issue is going to be the amount of people we have, because we need the same mutation with different manifestation, enough different so that we can really identify a suppressor gene. And for that, the ideal situation would be to have, the ideal is to have 1,000 patients. We won't have that in Myhre syndrome. So we can try, but it's a real challenge to have enough data to do the statistics on it. Because everybody has so much variation in your DNA. Kathy, me, we are all different. Even if we are apparently healthy, we are all different. We have variation all the time in our DNA. So to identify the one that is responsible to counterbalance the other mutation, it's going to be very difficult. Sorry, Kathy.
Oh, sure. So say like on Anna's whole exome sequencing report, you know, it just had the single SMAD4. But those, what you're talking about, aren't pathologic, so they wouldn't show up on the actual report, but it's in there. It's just not in the report because they only report those. Is that what?
Yeah, exactly. That can be variation. Everybody's different. You can be short, tall, strong, not strong. You can eat 2 croissants a day and be thin, and eat 1 a week and be chubby like me. So you have variation. The issue is to pinpoint exactly that variation, which is not pathological, so we don't know about it, and identify that this one is going to protect you against this disease. And that's a huge issue. So there are some scientists now at NIH, or you have other big organizations that are sequencing millions of people. But the thing is that we need to do it disease by disease, and we need to have enough people to be statistically significant. So that's the big issue for us. So for now, since we are far from understanding suppressor genes in Myhre, the strategy we have now is really to act on the SMAD4 mutation, or act on try to destroy those myofibroblasts that we have too much in Myhre, or try to to destabilize this SMAD4 complex with the other with other molecules. So that's the way we go now with Myhre.